Now it is. So I agree with what Winfried said, but I do want to point out some differences between the way we view things in the United States and the way they're viewed in Europe. We do have all these drugs approved for use in the United States, as well as just some additional comments I want to make about treatment to sort of expand on some of the things that he talked about. I actually am a little bit more optimistic than that. I actually think that the majority of patients with fibromyalgia, if they get to a center that knows how to appropriately use non-pharmacologic and pharmacologic and procedural therapy together, that the overwhelming majority of these patients that I come in contact with or I see actually can lead a fairly normal life. The studies are incredibly biased in a number of different ways with respect to the populations that they draw some of the data from, and the fact that in most of the people in routine clinical practice are not facile at using drug and non-drug therapies together. They don't know what drugs to use. If they know the drug to use, they don't know the dose or the way to use it, and they don't know about or have availability of a lot of the non-drug therapies. So it's not surprising that in a lot of our sort of population-based longitudinal databases, it looks like these patients never get any better. I'm not nearly that skeptical about the fact that even our current treatments work fairly well. Let me start with drugs, because it turns out that all of the drugs that work in fibromyalgia match up nicely with neurotransmitters that are known to be abnormal. So one of the things that I'm not really just a fibromyalgia researcher anymore. I'm a pain researcher. I study almost every type of chronic pain. And we have had more positive trials of pain drugs in fibromyalgia in the last 15 years than almost any other field of pain. Because I think we do understand that the drugs that are going to work in fibromyalgia are these drugs that are impacting neurotransmitters in the central nervous system that are either too high or too low in people with fibromyalgia. Having said that, I completely agree with what Winfried says, and our golden rule in the entire pain field, this is not the fibromyalgia field, this is the entire field of treating chronic pain, is the best that we do is that our drugs will make about a third of patients that we give them to 50% better. That's as good as it gets. But let me be clear about this. That is how well a non-steroidal anti-inflammatory drug works in osteoarthritis of the knee. So that is, we're not just talking about the fact that we don't have very good drugs to treat pain in fibromyalgia. We don't have very good drugs to treat chronic pain. And one of the things that bothers me about some of the guidelines is when you see this sea of drugs that don't work very well, and then you see non-drug therapies like cognitive behavioral therapy that at least look as though they're working better, there's a tendency to think, aha, this is a psychological disease. Again, this is not at all how you should view this. And again, one of the problems with comparing drug trials to non-drug trials is usually non-drug therapies don't have a placebo, don't have an active placebo. So non-drug treatments always look better because you're not comparing to an active placebo. When we compare a drug to a placebo, when we give someone a pill that looks exactly like that pill that isn't that pill, that is not a placebo. That has an effect in and of itself that is very powerful, that engenders a very strong placebo effect. That there usually is not a placebo effect in the comparison group of non-pharmacologic therapies. And so I just want to point that out for those of you who are not researchers by nature or don't look at a lot of randomized controlled trials, is you have to be a little bit careful about the inferences you make from looking at different types of trials, especially when you're comparing drug and non-drug therapy. I actually use drugs before I use non-drug therapies because I find that if I can find a medication that makes my fibromyalgia patients' pain better or their fatigue better or their sleep better, I find anecdotally, no evidence, that they are more likely to engage in an exercise program, that they're more likely to be able to focus in a cognitive behavioral therapy program. So I have written articles disagreeing with the EULAR guidelines for precisely this reason, is that I think for both practical reasons, especially in the United States, as well as more sort of pragmatic reasons, that I think that we often have to use a little bit of a drug before we launch into all of these non-drug therapies, that I am just as enthusiastic about their use as Winfried is. I'm just a little bit more careful about the order in which I'll place these. Now, we have a number of drugs that seem to be working by reducing glutamatergic activity. And if you look at these sea of neurotransmitters that are abnormal in some people with fibromyalgia, a point of emphasis is that some people have high glutamate, some people have high substance P, some people have low GABA, some people have low norepinephrine serotonin. It's not the same people. So if you give a drug like pregabalin to someone whose glutamate is not high in their brain region of the insula, it's not going to work. We actually showed that very clearly in a brain imaging study in fibromyalgia of pregabalin, that it worked the best in the people that had the highest glutamate levels in their insulin. It didn't seem to work at all in people who didn't have that problem. So if you look at all these different neurotransmitters, I don't expect that any single drug is going to work well in more than a third or a half of the patients, because all of these different neurotransmitters, because they're too high or too low, can be acting in combination to cause this final common pathway of an increased volume control setting. And I'm not sure we're ever going to have a drug that makes fibromyalgia pain 70, 80, 90% better, because there's so many different ways to get to this final common pathway. There's not a single pathway that is targetable with a drug, at least that we know of right now. So we can use drugs like ketamine or memantine in addition to gabapentinoids to try to reduce glutamatergic activity. I don't think cyclobenzaprine is available anywhere in Europe, is it? No. Which is not surprising that the Europeans didn't like it, because they've never used it. They never had the ability to use it. But it's actually my favorite drug to treat fibromyalgia. Very low dose. It's structurally very similar to amitriptyline, but at 5 or 10 milligrams, it has way less side effects than amitriptyline or nortriptyline, and it is my favorite drug, and at low doses can help a fair number of people with respect to improving their sleep, improving their sort of irritable bowel or irritable bladder, as well as making pain somewhat better. If you move over here, most of the drugs that we're using now to treat chronic pain and to treat fibromyalgia are drugs that in some way are raising norepinephrine and serotonin. Those would be the tricyclic drugs and the serotonin norepinephrine reuptake inhibitors. Norepinephrine is the more important of these neurotransmitters for pain, which is why selective serotonin reuptake inhibitors, and especially highly selective serotonin reuptake inhibitors, don't seem to be nearly as effective to treat any pain condition as the norepinephrine serotonin drugs, or even the older SSRIs like sertraline, fluoxetine, had some positive trials in fibromyalgia at high dosages, because those high dosages turn those SSRIs into a SNRI. They actually become much more noradrenergic when you give a higher dose of fluoxetine or paroxetine. If we move over down to the opioids, again, I don't think we should be giving people opioids. I think maybe we should be blocking the opioid system with low-dose naltrexone. I wasn't asked to talk about cannabinoids, so I won't talk much about it. I give a lot of talks in the U.S. talking about medical marijuana. I do think this is one of the conditions that cannabinoids should be considered for. But the big problem with cannabinoids is that we really have a lack of knowledge about what the optimal ratio of THC to CBD is. And I'm doing a lot of work in cannabinoids in other chronic pain conditions. There was a recent trial in osteoarthritis that showed that cannabidiol alone, which has no psychoactive effects whatsoever, and in fact protects against the psychoactive effects of THC, was effective in osteoarthritis of the knee. So I think there's a lot to learn about the cannabinoids, and how we can identify safer versions of cannabinoids. When I give advice about cannabinoids, I say people should start with pure CBD and then slowly, gradually move to a strain of marijuana that has low THC and high CBD. But that's not how any of the trials are done. And in fact, the trials in fibromyalgia of a cannabinoid, which were mildly positive, were of pure THC, which is nabilone. But if you talk to anyone that is using medical marijuana legitimately as an analgesic, they hate pure THC. So we have a lot of states in the United States that have legalized or decriminalized marijuana, but the federal government still has it as a Schedule I drug. So when we admit someone that is using medical marijuana legitimately and getting good pain control with it to the hospital, we can't dispense the marijuana in the hospital, and we will often switch them over to a pure THC preparation like Marinol, and they hate it because they get high. It doesn't have the CBD that's counteracting the THC, and they really don't like that drug as well as they like the high CBD, low THC strains of marijuana. So a lot we have to learn about cannabinoids, but the meta-analyses are very clear in pain, that in neuropathic pain and to a lesser extent in centralized pain states, these drugs are effective, and they're way safer and at least as effective, if not more effective, than opioids. So most of the lectures I'm giving in the United States are saying, don't use a medical marijuana unless you've tried everything else, because we don't know the right dose and the strength, but always use it before an opioid, because I hate opioids. They're just a terrible drug for using in chronic pain. And then gamma hydroxybutyrate, and even low alcohol consumption. This is one of my scientific achievements I'm most proud of, is that I was involved in a study done at Mayo Clinic where they totally accidentally found that the patients, a large number of patients that were being seen at the Mayo Clinic that were drinking 1 to 2 drinks on average a day, compared to people drinking 0 drinks or people drinking 2 or more drinks a day, that low amounts of alcohol seem to be protective against pain in this big fibromyalgia cohort. And that prompted Gary McFarlane in the UK to look in big epidemiologic studies, and he found the same thing. The only reason that this had never been found before is that in the UK, most people who drink alcohol smoke cigarettes, and nicotine does the opposite. Smoking makes pain much worse. Alcohol at low doses seemed to have a protective effect, and they were canceling each other out until Gary saw that Mayo Clinic article and then looked in the database at the people who were drinking low amounts of alcohol but who were not smoking cigarettes, and you very clearly see that protective effect of low amounts of alcohol. I'm not recommending you use alcohol to treat fibromyalgia, but I am recommending that you don't do what a lot of our pain clinics in the U.S. do, which is say, don't drink alcohol, that it's a bad thing. It's like there was no evidence in data before they said this, and now there's evidence in data suggesting that just like cardiovascular disease, a little bit of alcohol probably is good, more of that is probably bad. So this would be where I would put the different drugs, which is roughly, this actually matches up nicely with the Canadian guidelines, not the EULAR guidelines. The EULAR guidelines were more anti-drug, and I get why they're anti-drug. I'm just saying, as Winfried said, you can have different groups of people look at the exact same data and come out with markedly different conclusions. And so we can, but all of these medications that are listed here have one or more randomized controlled trials suggesting that they are effective. Again, they might not look as good in meta-analyses. The things that are in the second row here that I haven't already alluded to would be, again, the low-dose naltrexone and some of the older serotonin reuptake inhibitors at high dosages might be worth trying. If you have a person that's on, what is fluoxetine called? Is it called Prozac? Okay, fluoxetine. If you have someone on fluoxetine and you diagnose them with pain or fibromyalgia and they're only on 20 or so milligrams of fluoxetine, it may be very worthwhile to raise that drug dose to 40, 50, 60 milligrams, because the study of fluoxetine that Leslie Arnold did, the median fluoxetine dose that was needed, and that was a positive trial, was 45 milligrams, which is a higher dose of fluoxetine than most of us would commonly use as an antidepressant. So one of the things that I do, besides talk about fibromyalgia, is talk more broadly about using pain mechanisms to guide the treatment of pain. And we are now moving towards the fact that when you identify that someone's pain is more peripheral or nociceptive, the non-steroidals, the opioids, the surgery, and the injections are going to work preferentially, whereas once you identify that someone has more neuropathic pain or more centralized pain, the tricyclics, the serotonin norepinephrine reuptake inhibitors, the gabapentinoids, and yes, even the cannabinoids at the bottom might be effective classes of drugs to use for these different pain conditions. I really am a big advocate of non-pharmacologic therapy, and our group has probably done as many studies of non-drug therapies as we have of drug therapy. So I don't like getting cast as the person who likes drugs, because we really are very aggressive with respect to our study of non-pharmacologic therapies. And I think one of the reasons that people need these non-pharmacologic approaches is a lot of the non-pharmacologic approaches are aiming at downstream consequences of having chronic pain for long periods of time. It doesn't matter if you started out stressed or not. If you have chronic pain, you become more stressed. It's more stressful to live with chronic pain than it is to live without chronic pain. If you have chronic pain, you probably have decreased your activity level from what it used to be before you had pain. If you have chronic pain, it's probably causing you to not sleep as well as you used to be able to sleep, and you've probably gained weight as a result of having chronic pain. And then the last thing there are what psychologists call maladaptive illness behaviors. There's a lot of individuals that develop chronic pain develop ways of coping with their pain that are a way of them surviving their pain, but they actually are making them worse. And unless they go into a cognitive behavioral program and they're taught that some of the things that they are doing actually are unknowingly making their pain worse, then they won't necessarily improve and they won't necessarily get better. So all of these non-pharmacologic therapies are probably working in part down sort of at the bottom on the downstream consequences of pain, but all of those things can feed back up into what's the brain. And so the more of these things that people have, the more you have to use drug and non-drug therapies together. And some of these things down at the bottom are never going to be amenable to a drug. You're never going to make a bad habit that someone developed, give them a drug to get them out of that habit. And so a lot of these non-pharmacologic therapies are probably going to need to be used forever in our treatment of chronic pain, because this is a big problem of what happens to people that have chronic pain. So these non-drug therapies are really identical to what Winfried talked about. I think education is incredibly important. When I was doing more patient care, I used to start a half day of clinic that I was seeing 4 new fibromyalgia patients in with an hour lecture that I made all of them attend. And it turned out that I actually timed myself with a stopwatch. The total amount of time that it took me to see those 4 new patients was less when I did it this way, because every time I had to go in the exam room, I wasn't trying to give a new 20, 25, 30-minute lecture about fibromyalgia. I gave that all up front. And then when I went into the exam room with the individual patients, it only took 5 or 10 minutes, but I had an hour to talk about all the types of things that I've been talking about. And if any of you care, now the problem it's in English, is that I have a YouTube video of a patient lecture that I give that has widely been viewed around the world that basically describes this idea of brain pain and centralized pain in terms that is easy for patients to understand. This is a website that Dave Williams in our group developed. We tested this website in a randomized controlled trial, and it worked better in fibromyalgia than any of the approved drugs. Again, I'm not necessarily pro non-drug therapy or anti. We have to use everything that we have at our disposal to try to make people with fibromyalgia better. But we keep adding to this website, adding new modules to this website as we do studies that suggest we should add other components to the website. There have been a couple really good studies in the last couple years showing that cognitive behavioral therapy for insomnia works as well to treat chronic pain patients as cognitive behavioral therapy for pain. So we add a module now for insomnia to the Fibro Guide, because the evidence and the data is suggesting that that's really an important target for people with chronic pain, whether it be fibromyalgia or other types of chronic pain. And we keep trying to make this website better and better and better, and develop new versions of the website. If anyone wants to take this website and translate it into Norwegian, have at it. It's a Word version, so all the stuff behind the thing can be really easily changed. The only problem is the videos would still be in English, and that would be a little bit problematic. But again, I don't have to go through this. Cognitive behavioral therapy has been shown to be effective. I think some of the newer types of cognitive behavioral approaches, like the ACT therapy, like the study that Winfried alluded to, the emotional acceptance therapy that we've done recently, will be better than the old sort of cognitive behavioral therapy as it was developed about 40 or so years ago. And I think exercise is the most effective treatment we have for chronic pain. In fact, I tell my patients it is the most effective drug that we have to treat chronic pain. I truly believe that exercise is working in part by releasing some of the same neurotransmitters that we would otherwise have to give someone a drug to release, and there's far less side effects if you release those neurotransmitters endogenously than if I give you a drug that blocks those neurotransmitters all over your body. And so I think the problem is we can't give people exercise as a drug, and it's always been and probably always going to be a challenge to try to take that poor person with chronic pain that's hurting all over and convince them that it's a good idea to get into a exercise program. The one thing I would say that's helped me a lot as I've over the years, as I've gotten smarter and smarter, or I think I would be less stupid and less stupid, is I don't actually talk to patients about exercise anymore. I talk to them about activity. If you talk to patients about activity, their eyes don't bug out. They don't look at you like you're from another planet. But if you talk to them about exercise, they look at you like, you've got to be kidding. You've got to be kidding. I'm going to do exercise. But just these slight different ways in communicating to our patients can go a long way towards getting the patients to engage and to believe that these types of treatments can really be effective. And it is the case that the intensity of exercise that you need to do to get improvement in pain is far less than what you need to do to get cardiovascular fitness. You don't have to be doing 45 minutes or an hour of aerobic exercise a day in order to get the palliative benefit that we see with exercise across a number of different pain states. And then the last group of therapies that I just want to allude to, because we didn't talk about them, is that I think a lot of the neurostimulatory therapies are going to gain acceptance. Some of the peripheral neurostimulatory therapies that we've been familiar with a long time, like TENS units, can be helpful if people have regional pain, but some of the therapies that I'm more excited about are therapies that are either stimulating brain regions or things like peripheral vagal nerve stimulators, where you're increasing vagal tone by not having to put a vagal nerve stimulator on the person's vagal nerve and do a major surgical procedure. And I think a lot of these neurostimulatory therapies will, in the next 5 to 10 to 15 years, really be shown to have a strong place along with the other non-drug therapies and hopefully better drugs in the treatment of individuals with chronic pain conditions. So I don't know that I really need to say the summary, but I think that fibromyalgia really has taught us a lot about chronic pain. I think most practitioners were trained that if someone had pain in their knee or their elbow, there was a problem in their knee or their elbow. Now, in the last 20 years or so, with the advent of functional, chemical, and structural neuroimaging, most chronic pain conditions are more so brain problems than they are a problem in the area of the body where the person's experiencing pain. And so being able to identify those subsets of patients that have more prominent brain or central nervous system contributions to their pain opens up the right set of drug and the right set of non-drug approaches in those individuals. And again, I am not nearly as pessimistic as some people about how well we can treat people with chronic pain at present and how well we're going to do in the future. I actually think that if people get to the kinds of people that took 3/4 of a day and came to listen to lectures like this and are trying really hard in clinical practice to do the right thing and to make people better, I think most of us are able to make people quite a bit better. I think there's a lot of practitioners, unfortunately, that don't care and don't take the time to learn, and they are probably not making these people any better, often making them worse because they're doing unnecessary surgery, giving them opioids, or doing any number of things that can actually make these individuals get worse rather than get better over long periods of time. Thank you.